Hello, my name is Liam Fitzgerald, and I'm a second-year medical student at the University of California, San Diego School of Medicine. Today I'm going to be presenting a clinical vignette titled Milky Blood, the clue to solving the case. In this case, a 29-year-old gentleman with no significant past medical history presented with 1 day of severe epigastric pain and multiple episodes of emesis and nausea. He denied any alcohol abuse. Vitals were remarkable for tachycardia, and labs and imaging were notable for decreased bicarb with elevated anion gap, elevated glucose, elevated lactate, and lipase 3 times the upper limit of normal. Liver function tests were normal, and the CBC was considered invalid due to interference. A CT scan of the abdomen showed peripancreatic fluid and stranding around the pancreas without any biliary ductal dilation or evidence of cholelithiasis. The patient was diagnosed with acute pancreatitis based on the presenting symptoms, imaging, and elevated lipase. Due to the invalid CBC results, the blood draw was examined, revealing a very prominent lipemic layer, making hypertriglyceridemia the most likely etiology for the pancreatitis. The patient was treated with IV fluids and opioids for the acute pancreatitis and started empirically on IV insulin and dextrose with blood glucose titrated to 120 to 180. As you can see in Figure 1, the patient presented with triglyceride levels greater than 4,425 milligrams per deciliter. This confirmed the diagnosis of hypertriglyceridemia-induced pancreatitis. However, with a low-fat diet, insulin infusion, and ultimately the initiation of fenofibrate, the patient's triglyceride levels reduced to 173 milligrams per deciliter by the day of discharge. Severe hypertriglyceridemia is the third most common cause for acute pancreatitis and has been estimated to account for nearly 9% of patients with acute pancreatitis. The risk for developing acute pancreatitis increases with serum triglyceride levels, approximately 5% with serum triglycerides greater than 1,000 and 10 to 20% with triglycerides greater than 2,000 milligrams per deciliter. It is important to note that the triglycerides themselves are not toxic to the pancreas. However, it is the breakdown of triglycerides into free fatty acids by pancreatic lipase that causes lipotoxicity during acute pancreatitis. For hypertriglyceridemia-induced acute pancreatitis, treatment includes standard acute pancreatitis treatment such as IV fluids and opioids, in addition to the goal of acutely lowering serum triglycerides with an initial goal of less than 500 milligrams per deciliter. While fenofibrates and dietary fat restriction are often used to decrease serum triglyceride levels, hospitalists may be unfamiliar with the role of insulin infusion as a modality to acutely lower serum triglyceride levels. Insulin decreases triglycerides by enhancing lipoprotein lipase activity, an enzyme that accelerates chylomicron hypermetabolism to glycerol and fatty acids. Insulin also inhibits hormone-sensitive lipase and adipocytes, which is the key enzyme for breaking triglycerides down into fatty acids, which, as I mentioned before, are the major toxic factors causing symptoms in hypertriglyceridemia-induced acute pancreatitis. For treatment of hypertriglyceridemia-induced acute pancreatitis, initial insulin rate should be 0.1 to 0.3 units per kilogram per hour, with 5% dextrose infusion supplemented to avoid hypoglycemia. Hospitalists may encounter an option of plasmapheresis to acutely lower triglyceride levels. However, the evidence for this treatment is primarily from observational studies. One prospective study using plasmapheresis for acute pancreatitis from hypertriglyceridemia found no statistical difference in mortality, systemic, or local complications. In conclusion, hospitalists who encounter a patient with hypertriglyceridemia-induced pancreatitis should include insulin infusion as part of the initial management strategy to acutely lower the triglyceride levels. Plasmapheresis remains an alternative option, but data is limited to support this. We recommend initiating an insulin infusion while discussing the option of plasmapheresis with your endocrinology team.